Thank you to Christina and to the two previous speakers, Joy and Martin, for setting this up. So we now start with the core of the symposium. This session is concentrated on the landscape of malaria medicines for managing malaria. We have two short talks and then a panel discussion. We're going to start with a talk from Dr. Dorothy Achu, who is WHO AFRO, former National Malaria Control Program from the Cameroon, and she's chair of the RBM WHO Committee on Drug Resistance. She's going to speak on the current picture of drug resistance and the impact on the patient journey. She was, at the last moment, unable to join us in person, but has recorded a session. So if we could cue the recording, please.
There's a look that you get when somebody is getting ready to die.
Okay.
When the patient is 4 or 5 years old, you're the last person they look at, and they look right through you into your soul, and you can't save them.
Our job at MMV is to give countries the tools they need so that they can decide which is best for them.
Drug-resistant malaria strains in Southeast Asia could threaten the global fight against the disease.
There is no replacement for artemisinin-based drugs.
Independently, there is artemisinin resistance in Africa.
We're seeing smoke signs. We're trying to avoid that those smoke signs turn into a gigantic fire. We discover and develop new medicine in face of all the challenges. We'll continue to do it until the fight is over.
Anytime you have more than 0 people dying of malaria, that's too many, right? Let's get malaria deaths to 0.
Good morning, everyone, and thank you, Professor Dyann. Dear professors and partners, let me begin by thanking MMV for the invitation to contribute to this important symposium. I'll be setting the stage for the status of anti-malaria drug resistance in Africa and the impact it has on patient care. So to begin with, I would like to recall the case management guidelines before giving a snapshot of the anti-malaria drug resistance, and then we'll discuss a few strategies in place. So in terms of the guidelines, we know there is requested to have systematic diagnosis of all suspected cases of malaria, and there is, of course, prompt treatment, and depending on whether it's uncomplicated malaria or severe malaria, there are proposals of products or drugs to administer. For uncomplicated malaria, we have 6 ACTs that are recommended, the most recent of them being artesunate pyronidine, which was added in 2022. But for a long time, we've had artemether-lumefantrine, AZEC, and DP, which are the most used, and AL occupying 80% of the market share. Then for pre-referral, we have either artesunate suppository or injectable artesunate administered before transferring the patient. And then we have severe malaria treatments, which, of course, first recommended is injectable artesunate, but if not available, then injectable artemether could be administered, and some few countries are still using injectable quinine in the absence of this. So in some cases, we will have also primaquine, which is recommended either for as a transmission blocking agent, where countries have low transmission and they are going towards elimination, so to clear the parasite reservoirs, or it's used to address Plasmodium vivax or ovale infections as a radical cure. And again, very few countries in the region are using this because of the low prevalence of Plasmodium vivax. But in Southern African countries, we have a few countries that are using this protocol. The intention of this treatment is really to ensure that treatment is initiated promptly, is first of all confirmed and initiated promptly, but also that the parasite clearance is complete, especially by the third day of treatment, which is a 3-day treatment, and there is adequate clinical response. But in addition, we have public health benefits we want to achieve is to prevent onward transmission of parasites, but also to prevent the emergence and spread of anti-malaria drug resistance. So I'll talk about drug resistance, and in the case of ACTs, we have artemisinin, which acts rapidly, as you can see on the graph on your right. It acts rapidly to reduce the parasite biomass. And then we have a partner drug, which eliminates the remaining parasite over time. And it's the combination that ensures a rapid response within 3 days. So the efficacy of these ACTs depends on the efficacy of both components, the artemisinin and the partner drug. So all 6 partner drugs remain highly efficacious in our region, except for certain spots, which I will talk about shortly. So artemisinin rapidly lowers the parasite, but in case of reduced response, what we call artemisinin partial resistance, we have the time needed to clear these parasites that is increased. So talking about artemisinin partial resistance, it is really defined as delayed parasite clearance following treatment with artemisinin-based monotherapy or with an ACT, of course, containing artemisinin. So the graph on the right, on the left, just shows you the percentage of patients in therapeutic efficacy studies in Cambodia who still had detectable parasites on day 3 of treatment, which shouldn't be the case. And if you see in Western Cambodia, the red dots, this percentage kept increasing over time. So the spread was registered over time, and it was earlier than in Central and Eastern Cambodia. So when the percentage of these parasites goes beyond 10%, then it's very likely to have the failure of the drug, especially when it's associated with the partner drug failure. So this increased up to about 60-70% after 2013, and we can see what it had as impact on the use of ACTs. So when the partner drug is also failing, that's when we can talk about the drug failure. Artemisinin partial resistance has to also be associated, before it's confirmed, it has to be associated to the mutations of the PF-KELJ13 gene. So in brief, to have a confirmed artemisinin partial resistance, we must have, first of all, a high prevalence of the marker, the validated marker, which is PF-KELJ13, and we also have to have evidence of delayed clearance following treatment, especially day 3 positivity. There is also an in vitro confirmation which can be used to determine this, which is above 1% survival rate of the ring stage in vitro assays. So once it's confirmed, we can now categorize countries in whether they have confirmed cases or unconfirmed cases. So the World Malaria Report of 2024 showed us that we have confirmed cases in 4 African countries. And this is because all the criteria were met. First, we already know about Rwanda, which is where the first KELJ13 mutations were identified, but also rapidly spreading to Tanzania because it's a similar mutation. Then it's also been confirmed at a very high prevalence in Eritrea and as well as in Uganda. So we have 4 countries, but we also have suspected cases in in Ethiopia, where uh, it was detected early, the KERS 13, but was not accompanied by clinical symptoms, uh, or was not accompanied by a delayed clearance. We also have in southern Namibia and in Zambia. Of course, Sudan, it has also registered through the genomic surveillance networks increased prevalence of the KERS 13. So the malaria threats map also gives us an idea of how these ACTs are performing across the countries. So these are surveillance activities going on very regularly in countries. So this is data accumulated since the early 2000s when ACTs were brought on board. So if you see for artemether-lumefantrine, which is dense, that is the most used ACT, we have AL failure of over 10% registered in countries like Angola, Burkina Faso, DRC, Kenya, Tanzania, Uganda. Although we have this failure on ACT, we don't have any molecular marker to confirm whether lumefantrine, which is the partner drug, is having clear resistance. So it's mainly because of the artemisinin partial resistance, we believe that we are seeing these treatment failures in these countries. So in a small country survey of about 20 countries in 2023, we tried to understand the drivers of resistance, and the countries analyzed this situation, and we can see here the results that show the 5 highest drivers of resistance in these countries. So what is the impact we are anticipating that if we do nothing, there should be an increase in untreated cases and increase in transmission of these resistant parasites, and which may also result in increasing cases. There was a modeling conducted by Hannah Slater and team back that showed if we do nothing across Africa, there could be an increase, an additional 78 million cases in over 5-year period. So some of the cases that we are seeing increasing this past years, we need to understand whether it's part of it is not due to treated or undertreated cases that drive transmission. And it was also mentioned that if that is, if it is only about the artemisinin partial resistance, which means if the partner drug remains effective, we could still have increases about 10 million. And of course, if these additional cases happen, then we could also have additional deaths, which we estimated at about 80,000 deaths per year. So generally, if you look at the World Malaria Report, cases are increasing. Is that imputable in certain areas to drug resistance is something that we need to still understand. And of course, there is a yearly economic impact that would be a loss of lots of investments done in treatment if we do not contain the transmission. So in terms of how this will now affect the way we manage patients, looking at the drivers, and I will not repeat them, we mentioned the fact that parasites exposure to antimalarials is encouraged by presumptive treatment or monotherapies or low vector control, as we saw in the survey. This can only be addressed through improving access to quality diagnosis and anti-malaria drugs. And that is what we should be focusing on now as a community, strengthening diagnosis and treatment with quality assured drugs. There is also the risk of subtherapeutic drug use because of irrational use of drugs, non-compliance, and fake drugs. And that's where we talk about strengthening regulation. But the idea of diversifying anti-malaria use is also something, and abolishing monotherapies and also promoting the use of pramaquine is something that we can also put in place. And these are strategies in the new document that was published by WHO to address drug resistance. There is also need to strengthen prevention. So accompanying treatment with vector control and chemoprevention to bring down the transmission levels is also something we have to be looking at as we manage patients, and also empower patients and communities on the risks of non-compliance, on the benefits of doing a good quality of treatment and seeking care early. So this would like to wrap up by saying these are all strategies that are in the WHO strategy to address drug resistance. It's a framework that has 4 pillars. First, to strengthen surveillance to identify where the resistance is highest so that there are appropriate response strategies, to optimize and regulate the use of diagnostic and therapeutics. And that is where we come in to ensure that the treatment guidelines are respected. Third, to react and respond when resistance is documented and confirmed, like we are trying to do in the 4 countries where resistance is confirmed, changing their treatment policies and replacing them with policies that will reduce the spread of this resistance, and then stimulating research and innovation. And that's where MMV comes in on identifying what are the gaps in innovative tools, treatments that can help. But of course, we really need countries to take up all these tools because, of course, there have been guidelines, but the uptake is quite low for second line, third line ACTs, but also for drugs like pramaquine and even novel vector control tools. We need funding to be able to make sure that these strategies are implemented, and this goes around with advocacy, regional coordination, and accountability systems that have to be in place to make sure the strategies have been implemented. So I will end by the example of one of the strategies to address anti-malaria drug resistance, which is the innovative treatment approach using multiple first-line treatments, diversifying the use of ACTs. Of course, we know the rationale for that. So WHO published the guide for multiple first-line treatment in 2024, which proposes 2 methods for multiple first-line deployment. And this is either simultaneous deployment, that is by segmenting and stratifying the treatment by population or by age or by geographical region or even by level of healthcare. And also the other option is by rotation, changing the drug in each area either annually or biannually. So these are the 2 proposals for multiple first-line treatments. Now, it seems easy on paper, but it's a very complex strategy, and what that means for patients, is quite, and even for care providers, is something we need to understand and accompany them in implementing. So on the right, I put to you an example of a country trying to implement multiple first-line treatment. So in the first year, they have divided the countries into 3 areas where they deploy 3 different ACTs and they rotate each year. This is really a complex intervention that needs well thought through and supportive approaches to make sure that it works in terms of the availability of the drugs, in terms of supply chain, in terms of engaging with the health personnel, and even the communities themselves that have to receive these treatments. Why we switch from one drug to another is something that they all have to be accompanied to understand. So these are strategies that have to accompany, which I will not go through all of them one by one, but it needs a lot of leadership, needs a lot of funding to ensure that these drugs are available when and where they are needed so that it's successful. So I'll just end by saying we have challenges to ensure that anti-malaria drug resistance there is no spread. To keep it at bay, we have issues with the costs of a second-line treatment or innovative treatments that are not usually funded by the regular donors. We have costs of vector control, which when it's optimal, or chemoprevention, if it's optimal, we can also contain these threats. And then we have weak regulatory systems in countries and inadequate surveillance. But these are the challenges we need to deal with and we need to address. But there are also opportunities. We have a strategy, meaning we understand and know what could be done. We also have global financing initiatives. The Global Fund has AMDR initiatives and other partners are helping countries to access alternative ACTs through market shaping activities. And there is a promising line of new tools. But do we have a magic bullet? Magic bullet which will enable us to wipe out the remaining parasites, and we need to define what that specification could be of a new tool that can clean the parasites and that can be easy to administer and to rotate and be able to go against these resistance patterns. Of course, we need an enabling environment, and that's why we're really grateful for this opportunity for MMV thinking through this process and enable us to have innovative tools and strategies to face this challenge. So thank you very much, and we hope that the discussions will come out with very clear pathways on how to strengthen our response. I'll end with a few resources. Of course, you can access all these guidelines through WHO links. Thank you very much.
Great. I think thanks to Dorothy for giving us really a comprehensive picture of the challenges facing us with our, at the moment, most valuable medicine to treat malaria. So we're going to move on now to a presentation by George Jagoe from MMV, Managing Malaria Today, Extending the Range of ATCs in the Face of Resistance with New Molecules, New Combinations, and New Regimens. George.
Good morning. Thank you very much, Dyann. And it's a pleasure to be here. I know we're 20 minutes behind already, and I'm making my commitment to shorten my presentation because a bit of what I'm going to do is sweeper on some really good things that we already heard from Dorothy, Christina. So I'm going to try and fill in a few gaps, and I think it will inform the discussion later today. If we have a panel, as a matter of fact, coming up. So Dorothy gave a very nice overview of the pipeline, so I'm not going to actually break these down one by one, but let me just point out a few things. I'll use my pointer like this. First of all, there's some great partners in this room who contributed to making this what it is, and I'm just going to shout them out very quickly. Artemether-lumefantrine is here, as Martin said, because of Novartis. So first ACT in market, Novartis AL. First child-friendly medicine, AL dispersible, Novartis and MMV. First AL for kids under 5 kilos, Novartis MMV last week, or whatever. So it's really been it's a 20-year journey to get that part of the column where it is today. Other partners we've worked with throughout, and don't want to short shrift them, but let's say all of these have come through superb partnerships. DNDi helped to do the ASMQ. Let's jump to Vivax. The interesting story about tafenoquine, which was alluded to, the first single-dose cure for relapsing malaria, is it really took the GSK-MMV partnership to get something out of the lab. It had languished for almost 20 years as a known drug that wasn't ready yet to be deployed. And that final mile of actually making something that is promising, but to actually get it approved and launched is huge. So that's a story that I'm not going to be talking about too much more today, but the tafenoquine story in and of itself is a tremendous public health journey to get that product through. Primaquine, it's been around since 1952, so what's the big deal, one might say? The big deal about Primaquine is, even though it was approved 70 plus years ago, it had never been dosed for children with a stringent approved or WHO approved product. That changed last week, or in the last month. So I just want to call out Fosun as well, who made the commitment to get this very old but needed drug ready for use in children. And then lastly, we already heard about the remarkable breakthroughs, and Dorothy said, if you have a child who's dying of severe malaria, your first port of call will always be an artesunate-based product. Fosun took a very courageous and early position on that, and as a world, we're better off for them having dived into this space years ago. So look, I'm going to break this down into two chapters. What keeps us as drug developers and drug access people awake at night? And then I'm going to seed some of the things that we think are very promising. And then you'll hear a lot more later on today from folks like Caroline from Novartis giving you the real details. So it's a helicopter ride. But basically, the resistance concern is existential. My talk is only about cure. You'll hear about prevention from other speakers. But if we lose our artemisinin family today, we've lost the backbone of cure for hundreds of millions of patients. We're concerned about the imbalance of some great drugs getting more or less use than we believe they should be getting. And there are gaps of populations who haven't been addressed despite 25 years, let's say, of artemisinin therapies. Believe it or not, there's still gaps for patients who aren't being adequately covered. Dorothy talked about this, so I'm going to zip right through it. You've heard the signs, the worrisome signs of artemisinin partial resistance, or frankly, of partner drugs having problems. Let me dwell on this for a second, because this one kind of drives us crazy and has done for years. She mentioned the combination therapies that are out there. There's actually 5 fixed-dose combinations and a 6th one, which we don't talk about so much. But the 5 fixed-dose combinations have been available now for over a decade. The light gray thing you see at the top in the leftmost columns, that's artemether-lumefantrine. It's like an 800-pound gorilla squishing down all the other ACTs that haven't gotten to market. The second one you see is ASAQ. And then if you really look, these tiny little dark lines at the bottom towards the right, those are the alternative 3 ACTs that have never seen the light of day in any meaningful way. Right? So this is a bouquet of great products that aren't being used in a proportionate way. That's why she was talking about MFT. And we debated this at my APMEC, the Access Advisory Committee, in a small comité yesterday. MFT is hard. Dorothy pointed out all the interacting things you have to do. But even if it's not MFT, how about just switching? How about pyronary and artesunate being more widely used? That keeps us awake at night, because AL has done yeoman's work, but it's carrying a disproportionate load, and it's at risk. WHO recommended this years ago, use single low-dose Primaquine to kill gametocytes, so that even when a patient feels better and is no longer clinically sick, they're still spreading to their mom, their dad, their neighbors. Wipe out the gametocytes with single low-dose Primaquine. Today, the adoption, if we have any malaria control program directors here, they'll tell you, adoption has been infinitesimally small, right? Over 10 years after WHO recommended it. Why? Part of it's been the availability of products that can be used in children. So look, the patient groups left behind, this has been a real issue for MMV and for programs. Women being treated in their first trimester of pregnancy has been a no-go land for years. About 10 years ago, experts started encouraging WHO to move some of the ACTs into the safe use space in first trimester. WHO was rightly cautious to say, look, until I have concrete proof, which you didn't bring me during the clinical trial development, I can't say use ACTs in this very sensitive, vulnerable period of first trimester pregnancy. It's been thanks to, well, I'll get to that, what's been done to address that. Tafenoquine's use with ACT So tafenoquine is today used with chloroquine. If your country uses ACTs, artemisinin combination therapy for Vivax, it cannot use tafenoquine. That's been an issue. And treating babies under 5 kilos, as I just alluded to, was an issue until about a month ago. So this is what makes us excited about these challenges and what we think we can be doing or are doing and will be doing more of in the immediate and medium and long-term future. So let me jump into them immediately. So the innovative deployment, Dorothy talked about it. MMV advocated for this from 2008 onwards, backed up by some strong modeling from people like Maciej Boni. This has been 17 years we've been talking about this, right? It's great that WHO has guidance in 2024. It took a few pilots in Burkina Faso and Kenya to say, it's hard, can be done, let's get countries supported to try this as they see fit. Pioneering or testing it is one of those vastly underused ACTs I talked about. Mainly, there was some regulatory approval and WHO guidance issues that slowed this down for a while. When it finally got the thumbs up, it was seen as too expensive. So addressing the cost structure of this has been a major push by us, MedAccess, the Gates Foundation, and now 6 or 7 manufacturers will be making this in the next 2 years. It will get much cheaper. Transmission blocking, I've talked about that. Now that we have just a 2.5 and 5 milligram child-friendly dosing of primaquine, you're going to start seeing this combined for ease of use in regular treatment settings, combined with artemisinin combination therapies. And then I'm not going to talk too much about this, but it is an important program. This is really pushed by MORU, the Mahidol Oxford Research Unit. Fosun's been a big drug development partner in that. FCDO was an early pioneer in financing it. And MMB has come into sort of the formulation steps of this. A triple ACT is nothing more than taking, for example, artemether-lumefantrine and adding in amidiaquine. 3 makes a better wall against resistance than 2. That's the theory behind it. And actually, as Arjen Dundrup commented very nicely in a brief comment in The Lancet, there's a synergistic defending each other effect when you use lumefantrine and amidiaquine together. So they actually are like 2 linemen protecting each other. So it is an important breakthrough when it comes. So the whole point of this is reducing pressure on this ACT family. It's a precious jewel that we have. We can't lose ACTs. And to be very clear, even when we move to the next generation of drugs, which I'll talk about, ACTs are going to be here for a while. They're affordable. They're going to get even more affordable. And we're going to be relying on them. So this protection of this family is a critical public health priority. I'll pass quickly on this because I think you'll hear more about it later, but the top 2 bullets really refer to doing a better job of post-market capturing the experience of pregnant women so that we can push out the regulatory and WHO approvals of more ACTs besides AL that can be used in pregnancy. And then the clinical development protocols was something that we picked up with partners called MIMBA, basically said, how do you do early drug development where you can include pregnant women or women with childbearing potential? There's a lot that's gone into that. I can't do it full justice, but we are listening to that neglected population. Treating malaria in newborns, the beautiful thing is, and maybe Caroline will touch on this, that has been finally cracked. Our biggest concern now is not that we have a great product available from Novartis, it's will more countries adopt it. And frankly, we do need generic companies to look at that and go, hey, I'm going to add that to my product line as well, because AL is not just supplied by Novartis, it's widely genericized. And regional manufacturing is a big message that we hear from countries. We have started to address it. I don't have time to go into all the programs around supporting African manufacturing, but let's just say between 5 years ago and today, it's really changing quickly, and there's a lot of momentum in that space. So I'm not going to steal Caroline's thunder about Ghanian, and you've already heard Christina talk about it. But this is, I've been at MMV since 2008. We've been promising and promising and promising something that's not based on artemisinin, and we've tried. But OZ 439 was very hard to get into humans. It was a brick dust, I think you guys called it. We've had finally, with Ghanian, thanks to Novartis' diligence and our collaboration, finally we're on the eve of the very first non-artemisinin drug. It's critical, because even if this ends up in that space of sort of an AMR philosophy of it will be used selectively, knowing you have a non-artemisinin is night and day. We haven't had that, and it's been terribly anxiety-inducing as drug developers not to be able to bring something that wasn't artemisinin-based. So I'll jump over that quickly. My last closing comments are going to flesh out a little bit more of Christina's observations around why shorter dose, or with, as Adam calls it, the the holy grail of single dose, why this really matters. And it's not to get into polemics about this, because we acknowledge people who said, well, you know you're going to have some trade-offs if you go to single dose. We get it. But let's just unpack 4 dimensions about why single dose really isn't just a nice to have. It critically answers some things that should keep us all awake at night. Number 1, if you remember the Ebola outbreak, I don't know if you remember what MSF did, but MSF wanted to go out and, in essence, mow the grass of all malaria infections in communities that were struggling with Ebola because they couldn't afford to have malaria patients coming in with fevers into basically Ebola clinics. So how do I get out there and clean it out? What they did was used ASAQ for 3 days and mass treated populations in this emergency setting. Just stop for a second. 3 days ASAQ. Wouldn't it have been beautiful if MSF or the Ministry of Health in Liberia had basically just gone and gone, open your mouth, bing, one and done. Tremendous. In emergency settings, no question. Short or single is a big breakthrough. Secondly, compliance in the clinic. So even in a well-organized clinic, and a nurse or a doctor or community health worker is talking eye to eye and says to the mom, okay, you know you're going to go in day 2 and day 3. The compliance rates are still abysmal. It's at least, on average, between 20, and we see some studies that say 40% failure to comply. You talked about that. That's not going to go away. You can educate all you want. You can repackage all you want. 3 days will have declines in compliance on day 3 particularly. So let's go back to the community level now. Now you're not in a nice clinic. Now you're in that sort of dirt road setting where someone with a backpack who may have a 3rd grade education, whatever, is bringing you treatment for a woman who's never going to be able to make it to a clinic. At a community level, anything we can do to make a backpack health worker's job easier, or a community where literacy might be an issue, anything that makes their job easier, compliance is going to improve, no question. 3rd consideration. Alan McGill's words, which we're going to put up on a big screen at ASTMH, was, I want to extirpate malaria from target communities. So again, in the spirit of what MSF was doing, that was an emergency. But there are countries and some settings and subnational strategies, like Zambia, where they have said, I've got a community with fairly low prevalence. I want to get in and get the job done. I want to sweep. They'll be able to sweep through communities a whole lot better when, again, they've got the one and done option. This is a well-structured programmatic approach. An MDA done per plan is something you can really put your backbone behind. We'll make their jobs much easier if we bring this. And the last consideration, I think I've actually covered all of them. So basically, I just wanted to put out these dimensions. It's not just because we want to eliminate malaria with a single-dose cure. It's not just because compliance is an issue. It's all of them together that drives us to really lean in hard on trying to pursue the shorter and hopefully single-dose cures for malaria. It's my last slide. We're going to have a really good panel discussion. Diane's going to facilitate it, and I'm going to shut up and step over to my seat.
Great. Thank you, George. If I could ask the other panelists to join us on stage. We have chairs and microphones. While they're coming up, we're going to ask a series of questions, and we've pre-assigned the answers to the questions to certain panelists to give you sort of a range of perspectives. So I'm going to just ask each of the panelists to introduce themselves as we go across, and we'll start with Michelle.
Good morning. My name is Michelle, and I'm from Fosun Pharma. In Fosun, I'm in charge of the anti-malarial drug pipeline. Thank you.
Adela?
Hi, good morning. My name is Adela Ashie, and I work with the Food and Drugs Authority in Ghana. Thank you.
Hello, everyone. My name is Ghyslain Ngoma. I'm actually based in Lamboréné at CERMEL in Gabon, at the same time as well in Hamburg in Germany.
Morning, everyone. I'm Achan, a principal advisor at Malaria Consortium and an actively practicing pediatrician.
Great, thank you. And we have George joining us. Good, so the first question is, what are the regulatory and implementation hurdles of introducing a new anti-malarial drug for case management when existing drugs are working. And Adela has agreed to take this. So Adela, over to you.
Okay, thank you very much, Prof. Dyann. So for any regulatory authority to even start an evaluation of an application for a new drug for malaria treatment, there must be a demonstrated need, because as you said, there are existing products that are already working. So why do we need this one? So there should be a strong demonstration of advantage about what is existing. And so we are looking at, is it more safe than what is already there? We are looking at, is it going to provide better acceptability in terms of dosage regimen? Is it going to improve compliance? So these are the key things that we'll be looking at. And once we realize that that advantage is demonstrated, then we can go into the regulatory scientific requirements where they need to submit the dossier, and this should be in the common technical document format. And that's when they will bring the evidence to support the safety, quality, and efficacy of this new product. Some of the challenges we've seen over the period is, if you look at the CTD format, we have 5 models. Model 1, basically regional or administrative information. And then model 2 will be the summaries. But model 3 is the key area that looks at the quality in terms of the API manufacturing and then the finished product manufacturing. So these are the critical areas. There have been some challenges with the manufacturer bringing the information on the drug master file, which we usually say is in the closed part of the dossier. But then we have been able to come around it by saying that, okay, the manufacturer, if of the FPP cannot bring it, the API manufacturer can send directly to the regulator so that we're able to still review it and then make an informed decision. Then there are challenges if the API has solubility issues. And this is one of the big things the manufacturers have to go around and be able to demonstrate. Then when it comes to FPP, you just need to make sure that the product's manufacturing is completely described and then the quality safety aspects are there. One of the issues has to do with stability and then providing information on the stability indicating parameters. So at the time of release, you want to make sure that there's high stability indicating parameters so that during the shelf life, these qualities are still maintained. So these are some of the key things that we will be looking at. Regarding implementation, so that will be on the regulator side, we'll need to find out that because the new product, there'll be certain risks. So you need to bring a risk management plan. And for you to be able to implement that, you must have a strong pharmacovigilance system. And in Ghana, it is required that you must have a qualified person for pharmacovigilance who is resident in country to be able to do this, because we need to still collect data on the safety of the product while it's on the market. So this is a requirement that we'll be looking out for. For the programmatic issues, one of the key things is getting the product on the treatment guidelines so that it's more easy for prescribers to implement or to prescribe it for people to use. And so because these standard treatment guidelines have different timelines of being reviewed, you have to make sure that at the time of launch, it's close as possible to this timeline so you can get it on. So it's usually helpful if the product you are bringing is in line with the country policy on management of malaria or global policies, then it's easier to accept. Some of the hurdles that comes with maybe long registration approval timelines can be overcome if the product has pre-qualification from, for example, WHO, or in terms of AMA, if it is listed, then we can use the reliance pathway to speed up the registration. So these are things that you look out for. And for the program implementation to cost is very, very important. If the product has the same safety, efficacy, quality, and then it's expensive than what is there, how would the government be able to provide? Because most of these malaria medicines are part of public health programs, and so these are key things that affect introduction of new medicines. Thank you.
Great. Thank you, Adela. Okay, so we're going to move to the next question. We've heard not all ACTs are equal. Historically, lumefantrine and amidiaquin have dominated as the partner drugs. But what will it take for the others, DHA, piperacin, pyranidine, artesunate, to be more widely used? And Michelle has agreed to take on this question.
Okay. I think the 4 drugs, artemisinin-based combination therapies, they are good drugs and recommended by the WHO. So we know historically artemisinin lumefantrine and artesunate amidiaquin were the 2 ECTs firstly recommended by the WHO 20 years ago. And then they have good efficacy and safe, so they have been widely used in Africa. And because of that, there are a lot of generic manufacturers for both API and the finished products make these two drugs affordable, quite cheap. So it is also the reason to be widely used in Africa. And then the other two drugs, dihydroartemisinin piperquine and artesunate amodiaquine, are the newer HCTs approved by WHO around 10 years ago. And you know, when you are used to some drug and it is still safe, efficacious, so you are reluctant to change from what you are used to. So it is until recently. And on the other hand, as the manufacturer, they are not incentivized to develop the generic versions because it seems very limited market. And then it has been changed recently because of this artemisinin resistance threat in Africa now. And then because of the new policy, this MFT recommended by WHO recently. So now I think the generic manufacturers are encouraged to develop, the DHA piperquine and artesunate pyraneuridine, both API and the finished drugs. So in the near future, we will have more WHO pre-qualified DHA piperquine and artesunate pyraneuridine, and the prices will go down. And then that, together with this MFT policy, there will be a diverse use of all the drugs, the ACTs we have, also these two new drugs. And this will help to reduce the transmission of development and transmission of artemisinin resistance in Africa. Thank you.
Great, thanks, Michelle. I think a very important point here that it's going to take market shaping to make this work. So, okay. So we heard actually both from Dorothy and George the problem with low-dose primaquine. What are the challenges to adopting and recommending, low-dose primaquine has been recommended by WHO for more than a decade, and to reduce transmission of Plasmodium, in particular Plasmodium falciparum. And how could this impact artemisinin resistance? We were going to have 3 people respond to this. Dorothy is unavailable, but just to say that the guidance at WHO is extremely clear on this. So I think, what are the challenges? I'm first going to ask Michelle for the industry perspective, and then Adela for the country regulatory perspective.
Okay. So single low-dose primaquine has shown to be safe, also in Africa children with G6PD deficiency. And it is likely preferentially to reduce the transmission of artemisinin resistance malaria compared with the wild-type malaria because of the higher transmissibility and gametocyte counts in artemisinin-resistant malaria infections. And primaquine is a cheap drug. So I think the challenge is how to incorporate this, the low-dose primaquine into the routine treatment of malaria, especially in Africa. And we think, though, the co-blistering of low-dose primaquine with the ACTs is probably a good strategy. And sponsored by MMV, Fosun has developed a child-friendly dispersible primaquine, and it has been, it will be very soon WHO pre-qualified. And we have also developed the prototype of low-dose primaquine together with different ACTs. So now I think we need a clearer and a stronger recommendation from the WHO on single low-dose primaquine. And from as the manufacturer and from the industry, I think we are ready to supply the drugs.
Great, thank you. Adela, from the regulatory standpoint.
Okay, thank you very much. So in Ghana, we have registered a low-dose primaquine for the program to use as part of breaking transmission, and it's going to be used in the Greater Accra region where we are close to elimination. For us, one of the regulatory challenges was during the registration demonstrating bioequivalence, because they're existing products, and so if there's a new one coming in, must make sure that it's similar, so that we are not going to have low doses, which will be a problem. The other issue has to be with the availability of the product. As of now, it's only the 50 milligram that is registered. And so when availability is an issue, then there's the issue of substandard and falsified medicine that could come in. And then, so we need to be very vigilant as a regulator to make sure that the surveillance is high. But then apart from that, because it's only 50 milligram that is there now, there'll be scoring, breaking. So you must be able to demonstrate uniformity of dosage forms. And how is that going to be done? So that if you are giving to children, the right dose is given. I don't want to make sure have that one half has lower strength, which also leads to resistance. So these are the things that we're looking at, making sure that if there are other applications, we put in systems to speed up the approval. So if they're going to get WHO pre-qualification, so that reliance can be put in to make it faster, and then strengthen monitoring. But then again, there's also the need for training during the implementation for healthcare professionals, and then the acceptability, because when they hear Primaquine, they are hearing Amodiaquine, and then we had the issue with Amodiaquine when it was introduced. And so a lot of training education must go in. And this also ties to the country's strengthened system to identify safety issues. So that when it comes out, we're able to say that, okay, it is related to the product or it's not. So these are some of the things that we are looking at as part of the introduction, which should be starting in a couple of months. Thank you.
Great, thank you. Again, availability of the right doses and training, right? Making sure people know. All right, we're gonna next turn to the question of, the 3 or 4 dose regimens are standard in the care of diseases like HIV and tuberculosis. Why has the malaria community traditionally shied away from this level of complexity? Jane, we're going to turn it to you to answer this big question. And also, I think important is also talking about the need for various applications.
Thanks, Dyann, and I think a very interesting question. And I'll just share some of the reflections I think the community, the malaria community has gone through in those kind of decisions. I think one of the things that we need to consider is historically malaria treatment has been monotherapy. So the move to the ACT was a significant milestone, and the 2 drug regimens really did work quite well with more than 95% efficacy over many years. Of course, currently the issues around resistance are apparent, and the discussions around additional drug to the 2-dose regimen are happening. But historically, the ACTs seem to have addressed that gap and have done quite well. I think one thing that is also key for malaria treatment is really operational simplicity. Care for malaria is provided across multiple levels of the health system, including the community health workers. So really simple instructions to ensure that there is accurate dosing, there is no confusion, is quite key. And that is even demonstrated, I think, in the development of Coatem Baby, where even the dosage formulation for the young babies is supposed to be easy to provide. So really simplicity of administration is quite key. And that's contrary, for example, to TB, where the treatment is done within the context of a highly specialized program with individual training and long-term follow-up. So operational simplicity is quite one of those things that the community could be reflecting on. Another aspect is also just listening to George's presentation, limited drug options. I think the development pipeline for malaria drugs has been a particularly difficult journey. So at that point in time, how many drugs would you have to combine to really get the effect that you'd want? So the limitation in the options over the period of time could also have been an issue. Adela just mentioned costs, but really cost and supply constraints are quite key. What are the machinery around procurement of these multiple regimens for malaria, and how would the supply chains for these be ensured across board? And I think the discussions around MFTs really ably highlight the complexity around these issues. I think one of the other things is safety and tolerability. We need to also reflect on the fact that the large majority of people coming down with malaria, children under 5 and pregnant women, the safety margins in this population are quite tight. So reflection on safety and tolerability are some of those things in consideration. The other aspect is, I think also in the context of malaria, there's a key focus and investment on prevention. So we have SMC, the malaria vaccine, so a lot of investment has also gone into the prevention compared to the other diseases. And that also ensures that the treatment components are as simple as possible, but also a lot of investment on prevention. Mentioning severe malaria, I think in the context of severe malaria, it's really the need for a rapidly acting drug. And if one product can't do that, like we're having with ACTs, the need for multiple drugs, I think, remains one of those areas that is not really clear. So the two diseases are kind of different: short course of treatment, rapid need for good adherence, versus long-term treatment with different approaches to the development of resistance that ensure that multiple drugs are required for the other diseases, but the two-drug regimen seeming to have worked quite well in the context of malaria. Of course, right now reflecting on the new challenges of resistance, and the conversations around multiple drug regimens are now started. So really a quick reflection on what those reasonings could be.
Great, great. Thank you very much, Jane. All right, then we're going to turn to future needs. Is there a need for a single dose? Which populations are at greatest risk in terms of accessing treatment? And would single dose help solve that problem? So, Ghyslain.
Thank you, Dyann. Thank you. Actually, listening to the presentation from Christina and from George, I think they've already justified very well single dose. And looking at the pipeline, the portfolio that they've showed, it is as well obvious that the future is, we can be confident because all the partners like MMV with the partners like Novartis, Merck, and GSK, and all the others, they are working hard, so we can be confident. But then between today and that future, when is that future? Maybe it's going to be in 10 years, but between now and 10 years, what do we do? And we're thinking of a single dose more like maybe in that future of 10 years. So what I want to introduce here is like with all the strategies that have been already presented, we had the audacity in Gabon with my Gabonese colleagues, some are here, like Peter Kremsner and Mikhail Ramata. We thought actually we could take the current drugs and make like the most better use of them. So we've taken sulfadoxine pyrimethamine, which is more for prevention, but excuse us, we thought, okay, we could go back with that for treatment, but then combine it with another drug, which is artesunate pyronaridine. So we are going then with the principle of multiple drug combination therapy, but then reducing it to 1 day, because there was that study that was done in the Gambia and Zambia that showed actually in asymptomatic carriers that Piramax, which is artesunate pyronaridine, could actually work quite well as a single dose as well. So we've made that combination, and actually I'm retaining my excitation because last week in Hamburg we presented the first results, having treated more than 900 people, and it worked. At least this is what we have. It works, like giving single dose sulfadoxine pyrimethamine plus artesunate pyronaridine, it worked. And for that, we thank like the good discussions that we had with colleagues from MMV, like Teams, Adam and Stefan. And we are still exploring that. And with that initiative, we are even now foreseeing to do a large-scale study with friends like Bernard, who is here, Abdoulaye Jimde, and Kike Bassat and Pedro Aide, and others. And for that, I invite you to read a paper that was just published on the 30th of October, where we are presenting actually that perspective. Just to say, like, we've mentioned the future and the future needs. And for me, I'm sitting here as well a clinician who is seeing patients in Africa And it's hard to only project like in the future when the next generation antimalarial drugs will come, but it is as well for me good to see what we're doing for the patients that I need at the moment. But from such an initiative that is coming like, we would say, from amateurs that we are, I want to invite as well pharma companies, maybe like modestly, humbly, to come and learn as well from us, if I can say, because this is as well what is extraordinary in the partnership. Me personally, but with a lot of my colleagues, we enjoy very much working with MMV and with all the pharma companies. But we appreciate as well like being seen as partners who can bring as well a lot that can be actually learned by the other partners. For the populations, I think it's very obvious, like the population that are in need won't change. It's the same population today, it will be the same tomorrow. Just maybe my personal thoughts are maybe not to be too much focused, like we've observed that when we were focused only on under 5, we were doing something that those people, when they were going like above 5, something else was happening. Maybe it would be good to have an approach where we are having like looking at the general population, of course, with interventions that could be targeting different age groups and genders and so on. But a general approach will be as well very good. So I stop here.
Thank you very much. Okay, we did have a question for the panel, which Dorothy was going to answer, on kind of the immediacy of the problem of artemisinin resistance. I think she covered that well in her talk. We have also, we're going to include a country reflection, and we've asked Adela just to say a few words about the approach in Ghana in anticipation of potential drug resistance.
Thank you again, Prof. Dyann. So I think that the presentation, the map showed that we do not currently have an agent resistance issue in Ghana, but that we are not waiting for that to happen. Pragmatic strategy approaches have been taken in to make sure this is done in collaboration with the program. For example, the country has approved several anti-malaria ACTs that are used as part of the multiple first-line strategy, and we are employing the geographical approach, so simultaneously all these medicines are available for use in country. But then the program will decide how geographically the distribution is to plan so that we do not have too much exposure at the same time. The program also engages in annual therapeutic efficacy surveillance, which is supported by the regulator in terms of market surveillance to make sure that we are identifying any substandard or registered products which could derail the efforts that we are making. And then there's strong push for the 3T, test, treat, and track. So even when the regulator is approving any anti-malaria medicine, even if it's a herbal medicine, we request that if the product is going to be advertised, they include that you must test before you treat, and then the program will continue the tracking. So these are the strategies that we are putting in place to make sure that we are pushing resistance as far as possible. Thank you.
Great, thank you very much. Now, I know we're running behind time, so I think I'm going to take the chair's prerogative. We had one more question, but it's more of a philosophical question than an answer. So I'm going to pose it to the group with Tim's permission. So if we look back, 20 years ago when ACTs were introduced, they cost about $5 in today's money. So what level of innovation would we have to have today to justify such a price? And what are the strategies for distributing the cost effects on, sort of on a new intervention? How are we going to look at that? And so I think we'll leave it there. So I think it's very important to recognize that leaps in innovation are critical, but they come at a cost. And we as a community have to think about sort of looking historically, how did we do it with ACTs, but how are we going to do it going forward, particularly in this financial crisis. So I think with the panel's permission, we will have not caught up, but at least made up a little bit of time. I want to take time to thank the panelists from different areas of expertise and geography, representing, I think, the diversity and the partnerships that MMB has. We'll go ahead, close the panel, and go to coffee break a few minutes late.